can see that that has started. So welcome everybody back to the second half of our meeting, of our board meeting. So we're going to take the Quality Academy business, then finance and performance, and then people. Of course, we'll deal with our partnerships, audits, and some governance matters. And we'll try and get all that done within the next couple of hours or so. Of course, people have committed themselves to beyond 3 o'clock for the closed items as well. So that's great. But what a good morning's discussion, actually. It was terrific, wasn't it? And the stuff particularly, I think, on pharmacy and on mental health and on procurement, you know, there's some serious stuff we're considering there. And I'm grateful to all of you for the energy and the contribution that's been made. So thank you, everybody. Okay, so I suggested moving to quality because, of course, we've got a couple of people who are waiting to speak to board, thinking particularly Sarah and Professor Rebecca Lawton. So we'll move to quality first. So, as always, we begin by taking the chair's perspective of the Academy, and in the case of the quality and patient safety work, which does make me wonder whether we should that should be reflected actually in the board paper, shouldn't it? Where section 4C currently reads quality, perhaps should read quality and patient safety. But it's just a suggestion, and I'm happy to work with Laura on that. But I know it means a lot to us that patient safety is on an equal footing, of course. So shall I turn therefore to Mohammed and Janet? I'm not sure which would wish to go first, or whether it's sitting with one of you. But I'll pass to you guys and ask you to bring to our attention the key points from the March and April Academy meetings, please. Thank you.
Shall I kick off, Janet, and then do you want to pick up the other one?
Yeah, that'd be great, Mohammed.
Thanks. I wasn't going to delve too much into the detail. I think the details there to be read. Things I guess I want to bring to the attention is that we've been developing the Quality Academy, the way it's working in terms of maturity. We've got a development session set for the back end of this month, 26th of May, which is after the next Quality Academy meeting on the 25th. I believe all the NEDs should have been invited to that as well. And if you're not, then please do kind of put your hand up and we'll make sure you get an invite. We think it's particularly important to be looking at our terms of reference, our remit and scope, and are we delivering on our ambitions for the Quality and Patient Safety Academy. We went through our normal structure within the Academy, looking at areas of assurance, areas of learning, and then also noting on all the reports that we were receiving. We have been making some progress in terms of joining up the dots, and interestingly, that we had the pharmacy discussion this morning, Max. We identified in the Quality Academy that I chaired back in March that we had quite a number of medicine safety related issues that arose from different groups and different sources, and we actually triangulated that together and said what we really wanted to see was a more in-depth report and analysis and a more discussion around medicine safety, and we've actually got that scheduled for the next Quality Academy meeting coming in May, and that just highlighted for me, and as we highlighted this morning as well, just the importance of medicines, and it felt to me that we won't, certainly I wasn't seeing as the chair of that academy, not to say the work isn't happening, I'm sure it is, but I wasn't seeing as a cohesive approach of medicine safety, and I've tasked the team to come back and give me that kind of update in terms of medicine safety. So that was a particular area of focus for me, which wouldn't surprise you. And we also had a look at the approval of a number of policies around medicines and medicine safety, which we did, and we had a written communication with the team. One of our real challenges has been the capacity of the meeting of the academy to be able to get through its business. We're trying something new at the next one with consent from Ray and Leanne and members of the quality team, which is to say that those items that are for noting, that we ask members of the Quality Patient Safety Academy to write to us in advance with any questions, and that we would park all of those items beneath the line, if you like, and unless it's a specific item or question for discussion, we don't intend to spend too much time in the meeting going through those items for noting. What's really important, therefore, is that we really focus on discussion, debate, quality improvement, and tapping into the experiences of you know, the fantastic brains that attend the Quality Academy, and making sure we're having that debate within the Quality Academy. So we're going to try this approach to see whether that helps us give sufficient time for debate and discussion, yes, but still allows us to get through the business of the day that we need to get through, and that's important for us to get through. So as an illustration, for the medicines bit, we've given, I think, 20 minutes for a discussion at the next meeting, but there are other items for noting that we've then put below the line, if you so to speak. And we've asked, Jackie will be writing out to everyone when she sends out the agenda with a note which will say, all the items for noting, can you please send us questions in advance? And we hope by doing that, we're also allowing for an opportunity that individuals who get questions on their papers have the opportunity to write a sufficiently kind of detailed answer, and they're not being caught out on the day with a specific question for which they may not have the information to hand. And that hopefully might give us better questions and better answers. And also we'll document those as part of the minutes and record them in the matters arising for any questions or answers. And we'll see how that goes. And we'll also test that approach when we come to our development session on the 26th of May. And that's probably, I think, all as much as I'd say, and I'll probably pass on to Janet for the session that Janet chaired.
Thank you, Mohammed. And I endorse your suggestions there, actually, about the method of dealing with matters to note. It may indeed democratise the questions, might it? People might feel more confident of, well, if I could do this just by sending a note in, that's a great idea. And good point about medicine safety and the ongoing pharmacy project, which has possibly really helped hearing about that this morning, hasn't it? So thank you. And Janet, shall I turn to you, please? Thank you.
Thank you. I will be similarly brief. You can see from the April meeting, there were 15 items, and you've got a detailed summary there, which even in 3 hours was a challenge. So we very much welcome a different style and approach so we can manage the flow of items through that academy. So I'm just going to draw out a few items from that meeting because you've got the detail. And for sure to draw out the excellent presentation from the palliative care update and the reassurance of a 7-day service. That was really pleasing to hear, and you've got more detail there. As regular, we have the infection control report, and whilst there's challenges, we felt reassured that there was processes in place to address those challenges and move forward. Maternity services we've got next. So the update coming, some of the papers were presented at that academy, and a opportunity for more contemporary questions today. Just to reiterate, the TV programme and the Yorkshire Midwives couldn't have landed at a better time given the Panorama programme and the Occupant 2 report to help reassure the public that actually there is something called a really holistic maternity service, and actually that's a good example of what it looks like. I'm drawing on the serious serious incidents report. There were a number to note, and we're awaiting reports on some of those incidents to better understand what went on. And we were reassured there was some immediate actions in place to mitigate. And number 13 was the quality and patient safety dashboard, and we've had that on the paper today, changes and movements. We asked for a more detailed educational summary, and there's actually a report on today that actually delves a bit deeper and more broadly for us to better understand, because it's a huge piece of work for the Trust, our transient student community across a number of professions, and we were keen to better understand how it influenced, shaped, or even opportunities to improve or at least reassure patient safety. So I'm going to end there as a summary, and if that's okay, Max.
Of course, yeah. Thank you very much indeed, Janet. And should we just, as a courtesy, turn to Karen and to Ray and just ask whether, is there anything from the work of the Quality and Patient Safety Academy over the last couple of months that you would particularly want to highlight to directors, please? So Karen or Ray, anything to add, please? Of course, we've read the papers, so.
Nothing additional from me, Max, but thank you for the opportunity.
Thank you, Ray. Yeah, and Karen, was there anything you would have wanted to highlight?
I think there's a very comprehensive written summary of both meetings, so thank you to Corporate Governance for doing those.
Yes, agreed, actually. Yeah, the quality of the reports are excellent. Yeah, thank you. So shall I pause for a moment and just see whether anything has arisen within quality and patient safety that colleagues would want to add? And Mohammed and Janet, don't mean to be testing anything here, but have you had the chance yet to meet the new, I want to get the title right, patient safety coordinators, the patient safety champions, the new posts that are being created in patient safety? Has there been a chance for the Academy to hear about their work and perhaps welcome them?
I think we've heard in the past about the role and the role being created. I don't think to date we've had a specific update from them. Ray might correct me if I've missed it, Ray.
Yeah, Ray?
No, that's, I think these are patient safety facilitators, Max. We're going to be working really closely with the new CSUs once the new structure is complete. So I think some of those individuals we already have, some more to be recruited. So it's a bit of extra people and some existing people who are going to be slotted into those roles. But because there's no the new structure isn't finalised yet, I think exactly who's going where isn't actually finalised yet either. So there will be that formal introduction to the Academy once we get to that point.
Thank you, Ray. That's great. I do welcome their role, and I guess I'm hoping that they feel at least connected in some way to the Academy, so that they can actually raise issues and perhaps assist the Academy, of course, with detail. So, yeah, thank you, Ray. That's fine. So, colleagues, was there anything that has arisen in the Quality and Patient Safety Academy reports for query or further detail? And if not, shall I move on to the 3 key items under quality? I'll do that then. Yes, great. Thank you, everybody. We're going to take maternity services update first, which of course has the focus on neonatal today. And I met with Sarah actually in the last week or so. We had to sit down and a coffee together and talk through some of the sort of CQC stuff, and it was great, a really useful meeting. We were saying how it's a challenge always to immerse ourselves in all the data and then bring the focus. And I complimented Sarah on the way she's been doing that for us and bringing to our attention the kind of key themes that we might want to think about. But of course, I do know director colleagues will have read the papers. Having done maternity services update, we'll move to research activity, given that we've got a guest joining us there in Rebecca, and then we'll invite Karen to update us on the vaccination programme before moving on from quality issues. So, shall we turn now then, please, to Karen and to Sarah for our maternity services update. As always, I've come to the Exec Director first, Karen, in case there's anything you wish to orientate us towards. So the microphone's with you.
Thank you, Chair. So 3 key things to focus on today, and Sarah's going to brief very quickly on those because you've got a full suite of papers. So the 3 things are Occupant and the requirements of us as a board for Occupant 2 and what we should be cited on, the staffing and the proposed staffing configuration going forwards as part of a 6-monthly review, and then any key highlights from the routine maternity and neonatal report. So with that, I will hand over to Sarah to take the floor.
Thanks, Karen.
Thank you very much. Good afternoon. So yeah, as Cameron said, there's quite a suite of papers this time for March and April. Apologies in advance to those people attending Quality and Safety Academy, as they will have heard some of this before already. To note as well, just that closed board have also received a couple of additional appendices, which includes some more sensitive information, which was felt not to be appropriate for open board. So I'll just draw that to your attention. So as Cameron said, I think one of the first things that we need to sort of get out there is to draw board's attention to the 2 Ockenden appendices, which you've got in your paper bundle. The first was a national letter to all trusts that came from, I think it was from the office of Amanda Pritchard and Ruth May et al. And there is very much a national ask that trusts continue to focus on the initial 7-8 safety actions that were emergent from the first Ockenden report. Board will recall that the focus of March's maternity update to open board was a position update on where we were as a trust against the 7 safety actions, and also a midwifery and obstetric workforce update. So we've actually met the ask for what was in that for that letter, just to clarify. The second appendices that you've got relating to Occupant is actually the full is the full report, the full second report, which emerged at the end of March. It's quite a harrowing read, but it is there, and there is an ask that certainly any board members and any non-execs, if they get an opportunity just to read it and digest some of the key points in it. So again, I think just the key points to pull out from that is that we're currently working through the additional 15 safety actions that resulted from the second report and doing a bit of a benchmarking exercise, excuse me, as well as preparing for a regional assurance visit, which we've got expected at the end of June. So I think the 15 at the moment haven't been a national request. We haven't been asked for any further information, but we're just starting to get our ducks in order so that we know where we sit. And as soon as, I think it's the East Kent report comes out, we're expecting that there will be another raft of dues that we're required to provide assurance on. I'll move on to it through staffing a little bit, but one of the other key points for board to note, which might, for those people that have been a bit closer to the Occupant information coming out in the press, is around continuity of care, which has been a bit of a hot topic. I would just like to provide that update that at this moment in time, we don't propose continuing or commencing any further models or pathways of continuity at this moment in time until we have achieved our recommended safe staffing ratios. So I just wanted to reiterate that. I know it's quite a topic. We're sticking with the models that we've got because we feel that they are they're really serving our most vulnerable members of our community well, but we won't be starting anything new. So moving on to a few of the other key points. So I'd just like to ask you to note that the biannual midwifery staffing paper was presented to March Quality and Safety Academy and also to People Academy. And I think it's already come to you earlier on in this meeting today for consideration as part of the overarching nursing and midwifery staffing paper. I think it's just important to say that paper is written to quite a prescriptive formula, which is required to meet the Maternity Incentive Scheme Year 4 Safety Action 5 standard. So that's why it contains the information that it does. So I think, again, there are no new requests of board coming from the 6-monthly staffing paper, but it just describes our plans to achieve the birth rate plus recommended safe staffing levels as a priority before we continue a staged approach to achieving continuity of care as a default position for all women by March 2024. We're very much breaking that down into, we hope that certainly by the end of the year we will be able to achieve 35 and then 50% quite rapidly after that. So that's it.
Just to let you know, we've still to come to that paper, so that context was actually really helpful. Thank you.
Okay, thank you very much. Okay, so next, just as a really quick note, the CQC action plan was subject to internal audit in March, and we were rated as a significant assurance on that. The only thing preventing us from a high assurance was an ongoing piece of work regarding our escalation policy, which is very well underway, but it's had some delays whilst we've been trying to align it with regional and LMS guidance that's emerged as we've been in the process of writing it. But it is very much in the final stages now. Really quickly, the stillbirth position for March and April, we've had 5 babies in total across the 2 months, and actually 3 of those were expected, and the details will be in the closed board papers. 1 case of HIE in March and 1 case in April as well, and both of those are being investigated by HSIB, as is our process. We've also had 1 further SI declared in March, and that related to a 40-degree tear. There are no neonatal SIs or harms to bring to board attention bring to board's attention for either of the months. The next thing to move on to is our major transformation event, which occurred in March, and that was in the shape of our maternity Cerner EPR go live. In the main, it went very well. It has impacted on all areas of the maternity service, but most particularly noted within our community midwifery colleagues who have essentially gone from using a majority paper-based service to going completely paperless. So that's been quite a radical change for them. We've also obviously had the inevitable teething problems, but we're continuing to work through those. And some of that includes our ability to pull data reports. So we're working really closely at the moment with our BI colleagues to make sure that that the data that's going in is coming out in an understandable way, and that we're able to do something effective and use that appropriately. So we do expect that there might be some minor disruption over the first few months, but we've got a plan in place as to how we make that as smooth as possible. The April paper bundle also includes the quarterly perinatal mortality review toolkit report, and I just need to bring that to board's attention because that again is another requirement of the maternity incentive scheme. The service is actually exceeding or meeting at least the standards that are required within that. So there's nothing to bring to board's attention that's of any concern with that report. And then finally, the paper bundle also contains a copy of our training compliance report. Board may recall that there was a 3-month pause on mandatory training within maternity on the run up to go live, which was really required so that we could make sure that every single member of midwifery staff, or as many as possible, we could get through the Cerner training to ensure that smooth, effective transition to go live. Now, inevitably, that has led to a bit of a deterioration in our training compliance position. However, our professional development midwife has worked really hard over the last couple of weeks and has formulated a recovery plan, which we've enacted already. So all mandatory training is back on. We've got a comprehensive plan as to who's responsible for what and how we're going to deliver that. I think particular areas of focus for us include obviously our safeguarding children measures, which actually has already improved on the data that's been provided to board. So we're seeing an improvement immediately, and we are working towards an 85% compliance with safeguarding by the end of May. And then just to finalise with that for further assurance, I do want to add that we remain on target to achieve our 90% compliance in all staff groups attending our prompt emergency training. And again, I think in the background of Occupant, that's a really important one, that despite everything we felt that we really needed to continue to maintain our emergency training so that all staff were prepared and able to come, to deal with any obstetric emergencies in a timely way, and that there wasn't a compromise there. So I'm hoping that was enough of a whistle stop, and I've got everything everything out there that you needed, and I'm happy to take questions.
That's great, Sarah. Thank you very much indeed. And of course, I've mentioned before, Sarah, you do a great job actually of bringing us to the key points, and colleagues will have read the papers, of course. So thank you. Thank you for everything you do in this hugely important area, of course. Can I just remind director colleagues, perhaps particularly my non-exec colleagues, that the letter Sarah refers to, it was only last month, and it came, of course, from Amanda Pritchard and also from the chief nurse and the national medical director. And it's just worth reminding ourselves, the board, that right at the beginning of the letter, it says, your board, this is 1st of April, it's only last month, your board has a duty to prevent the failings found at, and it mentions other particular hospitals. Your board has a duty to prevent those failings. And it reminds us of the 4 key pillars of the Ockenden report. They're very easy for us to note. Safe staffing levels, a well-trained workforce. Are we learning from incidents, and are we listening to families? That's the 4 key pillars. So, Sarah, I didn't mean to steal any of your thunder, but I thought it was worth just reminding colleagues, and with all the various diverse responsibilities we have, of the nature of the push there. Our board has a duty to prevent, and that's the 4 key pillars. So, Sarah, thank you very much for your briefing. As always, I'll just turn to John, our maternity safety champion, non-exec champion, just to see whether John would wish to add anything. So, John, could I bring you in, please?
Thank you, Max. Yeah, I have put a comment in the chat about the excellent presentation, so I won't embarrass you any further with that, Sarah, but well done for that. It was actually a question around the comment, Sarah, for further assurance. I was quite heartened to hear what you said about mandatory training and the move towards getting ourselves to a compliant position. But for assurance purposes, I'd just like to know whether you feel there are any associated or residual risks to service given the lag in mandatory training at the moment, please.
Hi, John. Thank you for that. I think my honest answer at the moment is no, I don't. We've not seen any recent datexers or any incidents that we can directly attribute to any failings to provide mandatory service mandatory training in specific areas. I think things like safeguarding are obviously real key to us, but I think it's actually quite a live subject within the unit. So although staff haven't attended the formal training, I think it's a conversation that's very much day to day, and I think that by having certainly our safeguarding specialist midwife and her support person, the conversations are happening in a timely way, and staff are constantly reminded of the responsibility and what they need to do, and have got that support around them. So that's just one example. And as I said, I think our main priority was making sure that the emergency training, which meant that our staff were in a position to be able to deal responsively and appropriately with any clinical obstetric emergencies, has remained a priority throughout. So I don't think that we've seen anything, and fingers crossed we won't do in the time that we're taking to get everything back on track.
Thank you, John. Was there anything further you wanted to say there, John? A great question, and entirely relevant, of course, to one of the 4 key pillars.
Yeah, nothing further, Max.
Yeah, and great answer, Sarah, as well. Thank you very much. Yeah, Janet, can I bring you in, please?
Yeah, thank you very much. Same topic, no surprise, I guess, because inevitably we were all concerned where mandatory training needed to be paused, and we understand why that is. But we also understand how skill decay is a real issue, whereas particularly when we only update some of our skills annually, you know, if we're lucky, don't need to actually use them in that period of time. So I do feel reassured that this training is back on target, and I think I'm seeking to feel reassured that the whole multidisciplinary team, because there's some significant gaps in some areas, are going to be better prepared very promptly, so that when people call for assistance, those that come are equipped to actually respond. And I think something you won't see in your datex, but people might be feeling, is fear, because actually they're de-skilled, and that's a hidden problem, potentially. That's what I'm saying. Just a comment.
Thank you, Janet. Yeah, thank you, Sarah. Would you wish to say? Don't feel under pressure to answer every point made. Of course, sometimes I just simply want to share something with colleagues. But if there's any response you want to make there, yeah.
No, I think Janet's absolutely right, and we do know that that people do start to feel a little bit apprehensive if they feel that they're losing competencies, and what again we're trying very much to promote at the moment, and actually we've turned May into, you might have seen on some of our social media, we've turned May into our maternity safety month. We've not been asked to do that. That's just something that we felt was really important. So we're taking the opportunity to talk to our colleagues and to try and provide some support and have those conversations with people. So as part of the wellbeing one, that does sometimes come up, that people feel that they're lacking in a certain skill, and then it becomes the responsibility of the ward department manager or the matrons to actually signpost them and support them to pick up on those areas. So I do totally take your point there, Janet, but again, reassuringly, the emergency stuff has not stopped, and we are still absolutely on target to achieve what we need to do for maternity incentive, which is 90% of all staff groups. So as from an MDT approach, we're also very cognizant of that, and the fact that it's not just about midwives and obstetricians, it's about the wider team as well.
Thank you.
Thank you. Yes, thank you, Janet. Thank you, Sarah. There's some nice joined up thinking going on here, because we spoke with Sarah Turner earlier this morning, Sarah, about the mental health strategy, and with a particular focus as well on our colleagues and well-being within the trust. So this is sitting very nicely with that kind of fear of I'm a bit behind on this bit or that bit. Yeah. So thank you. I'm glad you're alive to that. Mohammed, would you like to come in, please?
It's a slightly different subject, Max, but I wonder if it's helpful, perhaps, if I replayed back a discussion that Sarah and I had at the Quality Academy. Sarah, it was just in relation to the we have a paper on the board similar to Quality Academy on research in the trust, and there was the update in terms of maternity and women from ethnic minorities or whose first language is in English, and we've done some excellent research in the trust with some 10 recommendations around how to improve care for those women. But what came out in our discussion at the Quality Academy was that wasn't connected, or not connected in a well enough way with what Sarah's doing and with the trust kind of delivering frontline care. And the bit I wanted to highlight, and I'll do it now because I won't be around for later, Max, was when we get to the research paper, is that challenge of translating research that we are doing ourselves in our own trust to clinical practice, and making sure our leading clinicians like Sarah are more involved in some of that research and are recognised as the experts. I think it's really important for us to do, and I still feel there's a gap here. I feel that we've made some progress in making research more visible, but translating it into our clinical practice still seems like a big gap, and I just wanted to highlight that because it came up in Quality Academy, and I want to say to Sarah, she gave an absolutely brilliant, candid, and totally honest response to that, and I was really grateful for you, Sarah, just being honest about it and saying actually we've not been engaged and it's not quite worked the way perhaps it should have done. So I thought that was a really good answer, and that gave me confidence that we were getting honest, really kind of deeply honest answers. That there was a gap here. We need to do more to bridge it.
Thank you very much, Mohammed. Thank you for sharing that, and that is brilliantly timed because we've just been joined indeed by Rebecca Lawton, who I know is passionate about translational research, about being able to translate research into actual action on the ground. So that's perfectly timed. And Sarah, thank you for what was obviously an excellent contribution at the at Quality and Patient Safety Academy meeting. So is there anything you'd wish to say in response to Mohammed reminding us of that?
No, other than that it is very much on our to-do list, and we're looking at how we can do that through our outstanding maternity services programme as well, how we can sort of join the dots up a little bit more, because I think, as I said to Mohammed at the time, I feel very much we facilitate the BIBS research, we give the team access to the women, but so we know what's going on, but we don't always see the outputs in quite the same way. So that's definitely the bit of the picture that we need to improve, and hopefully we'll be able to do that soon.
This is great. Just having that conversation is great, because if we're identifying that ourselves, it shows that we're alive to the potential for research to influence the way we work. So that's terrific. Thank you very much, Mohammed and Sarah. And is there any other questions or queries or points or further detail required in this hugely important area, of course? Sarah, we also mentioned earlier that as a board, we do intend to take a kind of a deep dive session as a development session to openly discuss maternity and improvements in maternity, which are obviously happening, but for us to move slightly away from a transactional board business sometimes to just being able to chat and talk about what's happening. So that's intended in the coming months for certain. Yeah. Okay. And in the absence of any further questions, queries, or anything else, Karen, was there anything else you would have wished to add, please, as exec lead in this area?
There's not. I'll tie up the midwifery staffing with the staffing paper later on in the people section.
Yeah, great stuff. Okay, so I'll just remind colleagues of the recommendations. We're asked to note the contents, of course, of the updates. There will be the midwifery staffing paper. We're asked to note that. Acknowledge the monthly stillbirth position that Sarah quite rightly brought our attention specifically to. Note the serious incidents that are referred to in the recommendations, and indeed appendices 2 and 3, which include learning and recommendations, good, from 2 recently closed HSIB cases. So that's what's asked of us as board. Are we all content to do that, and that we've got sufficient detail to feel able to note those? I think that's the case. Yeah, great stuff. Sarah, thank you very much as always for bringing yourself to board and for presenting yourself and being available to us for further queries. So extremely helpful, and well done again for just focusing us in on the key points. Thank you.
Thank you.
Cheers, Sarah. Thank you very much indeed. That's great. Okay, and then so still on quality and patient safety, of course. we have our standing item that we're becoming increasingly proud of, I have to say, of research activity in the Trust. And these have been terrific short briefings, but also really useful papers, of course, that are provided to us. So it's lovely that I can welcome Rebecca Lawton, Professor Rebecca Lawton, joining us today, who I think is just maybe going to focus in on perhaps 2, 3 or 4 key areas that she thought the board of directors would like to hear about. Rebecca, of course, we've read the paper that's been provided. Thank you to the authors of that. And I confess, Rebecca, I haven't told director colleagues of the work that you and I and Ray, and of course others from the Research Centre, were on with on Tuesday in an attempt to retain our Patient Safety Research Centre here. So if you wish to mention that, that would be terrific. I haven't stolen any thunder there, is what I want you to know. So Rebecca, the microphone's with you, and please do bring to our attention anything you think directors would benefit from knowing.
Thanks so much, Max. Can everybody hear me okay?
You're coming through clearly, Rebecca, yeah.
Brilliant. Definitely. And I think Laura's in charge of the slides, so thank you for that. So you're right, I'm just going to talk, I know you're running a little behind, so I will be brief. I'm going to talk about 3 projects. There are so many projects going on in collaboration with the Trust at the moment, but I'm going to hone in on 3, and then I'm going to finish by talking about the future of the Research Centre that you've just mentioned, Max, if that's okay. Right. So Laura, if you could move forward, thank you. So the first study that I want to refer to, which I think sounds like it probably aligns with a previous conversation, is a study which is funded by the National Institute for Health Research, as most of our research in the Trust is. This is a 13-month programme called Learn Together, and its aim was essentially to develop and test guidance to support involvement of patients, families and staff after safety events in healthcare. The idea of this came from the very real compounded harm that happens after safety incidents, and that can be caused by the investigation process itself to both staff and patients. So what we did in developing this research was we set about to co-design guidance and materials to be used as part of the incident investigation process. And we did this by working with patient safety managers in 4 trusts, people who'd been harmed, so harmed patients, some very seriously, and in which case we often involved their family members, and we involved staff. And we went through a 6-month co-design process where we worked through various information that they had provided, both in interviews and policies, about the processes that are currently in place for analysing serious incidents. So Bradford is one of 4 partners in this piece of work. We have 2 acute trusts and 2 mental health trusts involved, and we're also working with a healthcare safety investigation branch on this, because although they have done some work on patient and family involvement, they were really keen to learn from us and also to align their work with what we're doing. So we've developed the guidance now. You can see this on the slide, these nice documents here: guidance for patients, guidance for staff and guidance for investigators of incidents. And we're currently working with the Trust on 2 live serious investigations to use these tools and to see how they work as part of your investigations in the Trust. And we're working very closely with a clinical governance team, patient safety managers, etc. And we're getting really positive involvement and engagement from those people in the Trust. So I just wanted to say thank you for that. It's been really helpful in really piloting some of these tools within the Trust. It's also probably important to say that this is really vital work for NHS England and improvement. They need to do this as part of their patient safety incident response framework. So as we develop the tools with the Trust, we are feeding that back all of the time into national policy, and they are learning and using that in the development of their own tools and guidance. So that's really fantastic work that we're doing to support national level investigations too. Moving on, please, Laura. Any of these projects you can come get in touch with. I'm giving you a very brief overview rather than the details, so please do get in touch with us if you want to know more about any of them. The second piece of work that again we're doing in collaboration with the Trust at the moment is called Redeploy, and this is again funded by the National Institute for Health Research as part of their COVID recovery funding. And the aim of this particular piece of research was to understand the impact of redeployment during COVID-19 on nurse wellbeing, performance and retention. So for this piece of work, as you can imagine, we're working really closely with nurse leaders within this trust and within three other collaborating trusts, and within two other collaborating trusts, Oxford and Royal London. We've finished data collection now. That's involved interviews and focus groups with nurse managers, 36 of them, and 63 nurses who've been interviewed and completed surveys at 3 time points over the last year. And we're now working with senior nurses across trusts to disseminate those findings so they can use those in terms of informing their own policies and strategies around redeployment. And on the 18th of May, we're hosting a national stakeholder workshop with very senior nurses across England at policy education level to disseminate the findings and to develop a set of recommendations for redeployment of nurses. I think it's fair to say that what we've seen, and you can see from the slide on the right hand side here, is, and you will be very aware of this, there are a lot of top level directives coming from external organisations, and we obviously had the COVID-19 context. They had a huge impact on the way nurse managers were processing information and influencing their decisions on how to do redeployment in a fair way. Clearly, nurses didn't always experience redeployment as a fair and consistent process. That's one of the key findings of this, and that their own emotional responses to the decisions to redeploy did feed back into nurse managers' decisions around how they might redeploy. It wasn't a once only event. This was a kind of circular ongoing situation where nurse managers were learning along the way about how to do this more effectively. And I think we've learned from their learning in doing this research, and so hopefully have developed some really useful findings about how to do redeployment in a difficult situation, in a crisis situation, but how to do redeployment more routinely as part of everyday work too. So some really interesting findings there that we're feeding back to the trust. Next slide, please, Laura. The final piece of work that I wanted to talk about is quite different because this isn't actually research itself, it's a consultation process that we often do in advance of embarking on research. So this came from discussions a couple of years ago now with the Health Foundation about how we, I guess, educate and support the public to understand patient safety more. When you ask the public about patient safety, they often don't have a very strong understanding of what that means, and they don't really understand that things can go wrong necessarily in healthcare unless they've experienced that for themselves. So what we did here was we sorry, it keeps flicking backwards and forwards a bit, Laura, thank you. We did some work with young people in Bradford to try and understand what they knew about patient safety, with the aim of developing a guide for safe use of the NHS for young people. And so we've been consulting with young people across the Bradford district by working with community organisations. We've so far recruited 72 young people, but 42 of them face-to-face and 30 of them via surveys. And the young people we recruited face-to-face, who you can see here, but many of them are obviously covered up by the smiling faces for reasons you will all be aware of. 33% of those young people who were aged 11 to 19 came from British South Asian backgrounds, 33% were white British and 34% were from other ethnicities. So we've got a really good range of people of different ages and ethnicities involved in this work. We asked them about how they interacted with healthcare. Most young people were seeing the GPs, as you would imagine, dentists, a lot of interaction with dentists, the attendants in emergency departments and pharmacists. And when they were seeing pharmacists, it was most often to order repeat prescriptions or to get prescriptions for their relatives rather than for themselves. So they're interacting in that way. They wanted more information about the following list of things: how to book an appointment with a GP, what the waiting times were like when attending A&E, particularly when they turned up at A&E. They felt that was really useful information and might affect their decision about whether to wait around or not. Roles of different healthcare professionals within and across organisations. The cost of prescriptions, they were quite interested in that issue and why they had to pay those when they were over 18. How to give feedback, both good and bad feedback about care. The differences between the different emergency services that were available to them and when they should contact which ones. A lot of discussion around how to contact and access mental health services. And then the side effects of medicines, which they felt weren't really presented in an age-relevant language for them, and they were often having to communicate with their older relatives about these side effects. I think their understanding of patient safety was somewhat, well, it was interesting to understand what they thought of patient safety. They generally referred to patient safety as safeguarding issues, issues of data protection and confidentiality. But they did understand that they needed to feel safe and to get the right treatment, and that was part of patient safety, and also that they should be protected from obvious harms like sharps and things like that. So that was what they understood patient safety to be. And we're developing this work now with the other two research centres, patient safety research centres. They're going to do some consultation with their local populations, and then the aim of this consultation process is to start the development of this safe use of the NHS for young people guide. Next slide, please, Laura. This is my final slide, and as Max mentioned earlier, both Max, myself and Ray, and thank you both for attending the NIHR interview with us, went to London, to Twickenham for an interview earlier this week to present our case for funding for the second round of funding for patient safety research centres. They're going to be called patient safety research collaborations this time round. We think we did a good job of presenting our case. We came across as a coherent, embedded team, which was really positive. And this slide just presents a very high-level overview of what we'll be trying to achieve within the next centre in terms of the 4 themes for focusing on, which you can see in those 4 boxes in the corners, the goals, which you can see going around the outside in that loop, and our values as a research team there in the middle. And obviously our aim is to deliver safer care through research. And that's it from me. Welcome any questions or comments. And Laura, the last slide just has mine and our admin contact details for people on the board. Thank you.
Fantastic, Rebecca. Thank you very much indeed. Absolutely perfect, actually, bringing our attention to those 3 hugely relevant areas. The authentic engagement in incident investigations, redeployment perspectives, and indeed children and young people. And I shared with Rebecca colleagues that the Bradford District Partnership, of course, has a single spotlight focus on children and young people. And so I think everything they do in our research team will be extremely relevant to that. It struck me as well, Mohammed, I know you're just about having to go if you haven't already, and Janet, but that you might well be interested in the outcome of the research in children and young people's perspectives of using healthcare. It seems to me that it might be a matter of interest, Janet, for the Quality and Patient Safety Academy.
Very much so. Yeah, very much so, Rebecca. Thank you.
Yeah, that's great. Yeah, so it's very, very sensible things there. So absolutely perfect, Rebecca. 3 great examples, and we're all fingers crossed for what we hope was we did give a good account of ourselves. So let's hope that we might have secured that for Bradford for the next 5 years as well for patient safety research. Let's hope so. I'll turn to colleagues for any questions, thoughts, reflections on the paper and Rebecca's highlighting of those 3 research areas. Ray, would you like to come in, please?
Yeah, thanks, Max, and thanks, Rebecca. It's a shame Mohammed's had to leave us, actually, because I think it's evident from what Rebecca has said that the our Institute for Research in Bradford, and particularly the PSTRC, are really closely involved actually with the trust. You know, we don't just host them geographically. We work very closely with them and are very keen to extend and consolidate that relationship that we have. So I think Rebecca's given some really good examples of work which is actually going on in the trust and helping not just our patients, but, as Rebecca said, influencing national policy as well and helping patients throughout the country. Over the first couple of days this week, Monday, Tuesday, whilst we were down in London, we did spend quite a bit of time talking about ways in which we can strengthen that relationship and improve it going forward to work even more closely together. So, you know, I know Mohammed's left, but I just want to reassure people that we do work very closely with partners in research across all the different arms of research that we have in Bradford, and are very keen to promote and extend that going forward. So thank you for joining us today, Rebecca, and thank you for your presentation.
That's really helpful, Ray.
Thanks,
Thank you. Thank you for reinforcing the point as well. It seems to me that evidence of an outstanding trust would show links between research and clinical activity. So yeah, really helpful. Thank you. And Paul, would you like to come in, please?
Thanks, Max. Thanks, Rebecca. Nice to see you. Rebecca, I know the structures are ever moving in terms of ICBs, as they're now called, but there's a group called the Inclusive Innovation Improvement Partnership that sits as a formal subcommittee of the ICB. It's chaired now by who's the medical director of the ICB, James Bradford James Thomas. Sorry, and I'm just conscious that there's academic health science network membership, there's Leeds Academic Health Partners membership, there's quite a significant presence from LTHT, and I guess I'm just checking in whether you've got visibility as a group of Bradford-based professionals in respect to that, and whether that's another avenue for bringing the attention that quite rightly all this good work deserves, both in terms of brand awareness, but also in terms of adoption and you know, going forward across the ICB footprint. So I sit on it as the CIO nominee almost as much as the Bradford nominee, I think. But if that's not a route or an arena that you're currently familiar with, happily loop back to make that introduction, because I don't think we're in any shape or form poor cousins in that forum, but we could absolutely represent all of this good work to that audience going forward, which I think will become increasingly significant in the context of the wider ICB.
Is that the West Yorkshire and Harrogate footprint, Paul?
It is, yeah. Well, the West Yorkshire footprint now, Max, as we haven't dropped Harrogate, you know what I mean. But yes, in the context of the West Yorkshire footprint, Rob Webster was chairing it formerly, and James, now that he's got his portfolio confirmed, has chaired the last round. And I think it's just it seems to me as a forum, one that will increasingly revel in exactly the stuff that Rebecca's just been covering.
Perfect. Yeah, great suggestion. Rebecca, were you aware of the forum? And it seemed to me it'd be very useful to be plugged into that.
So thanks, Max and Paul. One of the things that we emphasised in the bid, and we emphasised at the interview, was that our future-looking patient safety research will be focused on the integrated care system and the integrated care, place. So I think if we don't have a seat there currently, Paul, at that meeting, it sounds like the perfect place for us to be, particularly, after April next year, where we really do need to be generating and disseminating our work across the system. It would be fantastic if you wouldn't mind putting in a good word for the team and perhaps getting us an invite to that board.
Oh, no, I'll certainly pick that. And Rebecca, I was also looking at the sort of printed material again around improvement science, because the other conversation that's opposite, right at the heart of that one, is the improvement science. I think, you know,
Yeah.
there's lots of eyes in that title, but I think it's a genuine attempt to cover the research, you know, to make that sweet spot between improvement science and change the academic community, and through my representation and others, that sort of digital transformation dialogue as well. So yeah, it feels like there's a perfect fit here.
Feels like a good place to be. Thank you.
Yeah, that's a really helpful suggestion. Thank you, Paul. And just in supporting your point, Paul, as well, the Patient Safety Research Centre has a reach, a legitimate reach well beyond Bradford. It's the Yorkshire and Humber Patient Safety Research Centre, so it would be perfectly placed within our local ICS. So thank you for that suggestion. That's great. If we can make that happen, that'd be wonderful. Thank you. And Rebecca, just on further supporting Paul's point, we had a good debate actually about, in maternity particularly, translating research into ways in which we conduct ourselves. So, and it was in the way of directors wishing to support that. So it's good to know there's lots of support for trying to achieve that. We welcome that. Were there any other comments, questions, thoughts for Rebecca? Really helpful highlight of 3 major projects with national reach as well. So that's terrific. Okay, are we all happy? We're simply asked to note that and continue our good work with you. So great stuff, Rebecca.
Yeah.
Thank you very much.
Bye.
Good to see you. Yeah, thank you again for joining us, Rebecca. Yeah, that's great. Okay, thanks everyone. That was really useful insight, wasn't it? Delighted to see the additional emphasis that we're putting now on research here. So it's great. This standing item's a good move. And as I say, I suggest it would be evidence of an outstanding trust that could show really strong links with research and amended activity. Okay, and so shall we move to the final main point on quality and patient safety, which is a brief update on our vaccination programme. And in Karen, of course, we have the local lead for that, and so we're grateful for that. And Karen, I'll pass the mic to you, please.
Thank you. It will be a very brief update because I need to run off and open the mental health session at 1:30 in Sovereign. So we're currently delivering between 7,000 and 8,000 vaccinations per week across the city. This is done through a variety of means and methods, through PCNs, through hubs, through pop-ups that are out of Jacob's Well. And the focus through the spring and the summer months is very much on over 75s, care homes, with the boosters and clinically extremely vulnerable, so they're getting a 4th booster, and then the 5 to 11s, which is a new group that's been added from early April to give those the opportunity for vaccination. The focus though at the moment, as well as that, is the planning for autumn. So in autumn we are expecting I suppose it's a 5th booster for some and a 4th booster for the majority. But we've actually been told that if there was to be another surge in COVID, we would be expected to bring that forward maybe at a week or 2 weeks notice. So again, a lot of sites we have paused. We don't step them down now, we pause them so that we can get them up and running very quickly. And there is a planning session due in the summer so that we can get together as a group across all of the different parts of the city that have been involved in this, VCS, etc., to actually say, you know, what do we do well, what could we do even better, how can we learn from that? One of the main points to say is that it is very much becoming business as usual. So that's how we are moving. It's a place-based approach to this, and it is working well. We've got a small amount of regional funding until the end of March that allow us to keep some key posts in. So the project manager costs, Rakea's role, which is around equality and diversity, some comms money as well. So everything is going to plan. The biggest risk at the moment is probably going to be vaccine supply going forward. So we know that it's pretty hand to mouth on a weekly basis. I think there is a worry. So just after Christmas time, sort of January, February, there's a lot of stock nationally that went out of date because they'd given out lots of stock to sites. So I think there is a concern that we might end up with stock going out of date. So the supply is not as fluid as it was before, but we are managing up to now. So I'll pause there and happy to take any questions.
That's perfect, Karen. Thank you very much. So as ever, we'll just pause for a moment and see whether is there anything in relation to our vaccination work that people would like to raise for query. John, would you like to come in, please?
Yeah, it wasn't a question, Max. It was a comment which I've already shared with you that I thought was worth sharing, and it could have come up just as easily under the research section. I've had the pleasure of taking part in the research for the 4th vaccine, and I'm no longer surprised by the excellent customer service I get because I've had that all the way through. So unfortunately, that has become business as usual. But what has been very interesting in that trial for me, when I was asked what my concerns were, we had a bit of a laugh together because I said my main concern was not to do with the vaccine. It was whether or not I could use the app that we were supposed to be filling in as a result to monitor our health. But actually the design of that and the way they dealt with the accessibility issues was organically very easy for me. And I think if anyone wants to look at good practice in terms of access, certainly for my impairment, and I'm sure for others around the design of an app, then look at that, because that happened without any consultation with me. And it was incredibly easy. So the point now is I'll have to start worrying about what they're pumping into me through the vaccine if they get all the apps right in the future, won't I? But I just wanted to feed that back because it has been an incredibly positive experience. Thank you.
That's important feedback, John. Thank you. So the quality of the app, Karen, and indeed, John, I think you did share with me that the personal interaction of that team were very strong. You were impressed by them. Is that right?
I'm no longer surprised by that, Max. It's great, but I've had it every time, so that's why I made that comment about that's almost business as usual now.
Yeah. Thanks very much, John. I can see Karen has noted that, and I'm sure we'll feedback as well. So yeah, thank you for those important points, John. I do realise as well that you're going to go slight clash, isn't there, with the neonatal work, I think. So I do realise you'll be leading shortly. So thank you.
I've been well primed though, Max. Thank you.
Yeah, no, absolutely. And of course you are our non-executive maternity champion. So it's great that you're there, John. It's right that you do that. So thank you. Yeah. Karen, thank you for the briefing. That's perfect. I don't think there's any further queries or questions. And Laura, may I just ask for the minutes that we note Karen's really helpful point that she would welcome the outcome of the redeployment initiative, which indeed Karen has complimented as well, as being tabled at the People Academy, so that can be shared with colleagues amongst that. So there may be an appropriate way to manage that, to do that, but that'll be really helpful. So Karen, thank you for your point there. We'll make sure that we pick that up as an action. Karen Dauber as well, I know that you'll just be back as you open this session. So thanks very much, Karen. That's, of course, no problem at all. Yeah. Okay, thanks, everybody. We've done really well there, haven't we? That's great. So we've got an hour or so to go, haven't we, in terms of the time set aside for this. So let's now take a pause. I think we will have a 5-minute break as well at some time, just in the next half hour or so. But we'll just take a pause and go back now to section 4B, which is finance and performance. And as usual, we'll begin with Julie as our non-executive lead in this area as chair, for the opportunity for Julie to bring to our attention what she would wish. And may I just give a heads up to Sarge, please, that I've picked up on this recent correspondence about share with directors waiting list analysis, and its analysis particularly, for example, by ethnicity and deprivation. And I do know that Mel and that Sarge and Paul have been looking at that. And I did just want to fairly give a heads up to Sarge in the hope that you might just mention that, Sarge. And I appreciate I haven't checked this with you, Sarge, but if it might be possible for the next board meeting to have something that we feel able to publish in terms of that analysis, that would be great. But I accept I haven't had the chance to ask you about the timescales for that. I'm really keen that we do take a front foot on that. It's about understanding inequalities, and as directors we want to see whether there may be factors that relate to inequalities that apply to our particular waiting lists. So Sarge, thank you. If you're able to mention that, that will be great. But in that spirit, I will turn to Julie, and maybe I just ask Julie what she would wish to bring to our attention from the work of the F&B Academy. Julie, please.
Okay, so a whistle-stop tour through the 2 reports that you've got the detail of both meetings. So I won't go through the reports separately, I'll just pick up the highlights of the 2. So over March and April, we've signed off 21-22 finances. draft accounts have been submitted, spent 532 million as a trust and delivered a 1.4 million pound surplus against a break-even plan. We said in F&P, well done to both the organisation and the finance team. It looks as if it's easy to spend 532 million, but the rules on spending just that amount make it really difficult. It's a good job in a difficult year. It's a good job. So well done to the organisation. Well done to the finance team for getting those accounts in. Spent 37.7 million pounds of capital in 21-22. Again, it's a good news story and some really good schemes in there when you look at the detail of what we spent, and some good reasons to celebrate investing in those areas. Looking forward to 22-23, we've signed the financial plan off. We approved by a board on 14th of April, so we've been through the detail as a board. We know there's a job for CBUs to do to start delivering efficiencies, reduce waste, and we will track that through F&P. So we'll track delivery of a 2.2% efficiency required through finance and performance. And we'll start to focus early on in what the recurrent position of that is like, what the year after that looks like, because we understand it's not just how we deliver 22-23, it's how we make sure we're financially resilient going forward over the difficult years. Capital plan of 23 million when we signed it off in F&P. Coming to performance, still some challenges, and we talked about the recovery period maybe being up to 2 years, and we really need to be cited on that as a board. This is not a quick recovery. Lots of work going on, lots of issues with people, numbers turning up to A&E, lots of issues still with people on waiting lists, but some great work going on to kind of tackle those initiatives. What we do see now is we see the improvement plans in F&P. We saw the cancer one in April and we saw the RTT one in March. And they really pulled together all the improvement areas that are happening to help tackle that recovery plan. Areas transformational, proactive, business as usual. So improvement across all those 3 areas, and encourage, and we'll see the urgent care one in our next meeting. What's really good to see is the work happening in different place footprints. So we're not just doing stuff in the trust, we're working across Bradford, we're working across the Bradford Place, we're working across West Yorkshire. So great to see how those reports, that are really good reports now, actually track the improvements across those areas. So really encouraging to see that. Good update on the Actors One programme, which was paused over COVID. The team were working on vaccinations, on different things. That work has started again, and again adds to our improvement agenda. We looked at the procurement strategy. We've talked about that. We looked at the risks, noting that the financial risks will improve as the new year starts, just because of the length of time to deliver those. We note that those risks will improve. We haven't seen that yet. And then just to say, our next meeting in May this month, we will be having an hour to focus on improvement. So how do we try and improve what we're doing? And we want that to be a bit of an interactive session, very much of a focus on how do we do our business better. Probably not in the detail quality of doing, but I think probably our areas more defined, but we still want to look at how do we make sure we can do that better in the spirit of improvement. So whistle stop tour, you've got the reports in detail. I think they're the things you need to know. I'll pass over to Matthew and Saj.
Thank you very much, Julie. Julie, could I just check with you whether are there particular areas that you see as ripe for improvement that you're hoping to focus on, or is it a kind of general position?
From a finance and performance perspective, it's really about academy. It's really about seeing what do people around the table think. You know, how do we get contribution from everybody, not just from non-execs, from people coming to the meeting. Are the meetings being worthwhile for people coming? Are we spending our time in the right areas? So we're hoping to pose some questions that actually get into some of that, and a bit more interactive than just sending a questionnaire out and say, how are we doing? So that's what we're hoping for. We're trying to prime some questions, but I don't know yet what will come back, and we'll listen to what comes back and how can we improve that.
Thank you, Joe. That's really helpful. So it's about contribution and interaction and the way the academy works. Yeah, thank you. Thanks for that. That's helpful. Yeah, I didn't know if you were talking about particular, for example, clinical areas or.
No, we're talking about how do we do our business better as an academy? How do we use our time better? Are we using the time well? Can we do it differently?
Perfect.
Just listen to some of those thoughts.
That's great. Thank you very much indeed. Thanks, Julie. And I'll now pass then to, is it Matthew first or Saj first? So Matthew.
Yeah, not a lot to add to that really helpful update from Julie. I'd just like to reiterate the point around the capital programme spending 37 million was a big ask for the organisation, and we've got some, still developing facilities, but some fantastic facilities across all the domains of the programme really, whether that be medical equipment, digital or estates and buildings. We've still got 23 million to spend in 22-23, which seems like a big reduction, but it's still a lot more than we had pre-pandemic in our normal capital programme. So still an opportunity to improve, but we do need to be mindful of the backlog challenges that we face as an organisation. And then just turning to income and expenditure, close the years, as Julie said, with a positive outturn. We've gone from feast to famine really. It's a very different year, 22-23, and starting the year with quite a different challenge from a 26 million pound financial improvement target for the organisation. So we're just working through the process by which we would deliver that by the 31st of March. But it is a very different ask of our clinical business units this year than it has been over the previous 2 years.
Thank you. Thanks very much, Matthew. And it's great to hear the chair of the academy pointing out the good work of the finance team there as well. So great stuff. Thank you, Matthew. Yeah. And Saj, may I turn to you, please?
Yeah. Thank you, Max. There's nothing specific I wanted to pick on. I think Julie's covered all of those points really nicely in what we've covered off in the academy. I will move on to obviously the question around waiting list analysis that you posed, and I'll bring in colleagues like Paul and Ray to assist with this one. Obviously, board will have been and have been cited on the work we've been doing around learning disabilities and the reports that we've brought through now, and the fact that we have been able to hardwire into our systems both the identification and the action subsequently that we take upon identifying somebody with a learning disability and them needing to go on to require surgery. In terms of the waiting list analysis, to pick up on the wider health inequalities piece, that is work that is proving to be, for many organisations up and down the country, in fact, very complex and complicated in terms of being able to get the data analysis. Not so much in terms of individually looking at what the IMD score is, so the index of multiple deprivation, or what the ethnicity of the patient is, but it's when you bring all of those data fields together and try and marry that with the waiting list is what's proving quite a challenge. And I am going to come to Paul on that in a second, because I think Paul will be able to outline some of the work that's happening there. But then secondly, once we get that view, then it's about ensuring that we've got a consistency so that we're not doing something that's out with what WIAT or region are doing, and indeed nationally around prioritisation, because there are some some ethical debates and discussion and research to be undertaken within those areas. So we are making progress on that, perhaps not as quick as we would have liked, but that demonstrates complexity that we're dealing with in terms of the waiting list analysis upon this. We've got, like I say, the individual data points there, but we haven't been able to marry those up. But I'll bring Paul in to perhaps elaborate on that, and then I'll pass to Ray to provide an overview of the consistency and work at WIAT, perhaps. Paul?
Yeah, thanks, Saj. And Max, I think Saj has been extremely comprehensive there. I mean, we are aligning the resources within the BIDQ function and ops performance to ensure that we can understand what the numbers tell us insofar as they tell us something. In terms of timescales in relation to update the board more specifically, I think we can assure colleagues that we can bring something back in the next board cycle. The thing that we've been keen to do is make sure that we can marry the insight with an activation plan, because it's one thing to have the detail, and then the next thing is to, well, how do we operationally deal with that, as the learning disabilities example has demonstrated. So I think what we'd want to do is sketch out a roadmap going forward that says this is what we understand, and this is the steps that we anticipate taking consequent to this, to make sure that if we agree a set of actions, that we can actually see those actions through The other thing I would say, Max, not to obfuscate things, is that what's becoming increasingly clear is that actually the numbers of people on waiting lists, when we hear numbers of 5 or 6 million nationally, that's not the number of people waiting on an inpatient PTL. That's the number of people waiting across the totality of waiting lists. And when the real challenge is going to come in twofold. One, in terms of those waiting lists that traditionally, or those people who haven't yet found their way onto an inpatient waiting list, i.e. they're waiting for a first outpatient encounter, and that's the vast majority of people. And then the second thing, again, without overextending the conversation for today, is the increasing concern about the missing millions and the feeling that the characteristics and where those populations are drawn from are even more likely to be drawn from people who either are socioeconomically deprived or for some other reason marginalised within our society. So I think it's just to give the board a collective sense that this is going to be a long haul. This is going to be a marathon, not a sprint, but we are very conscious of the need to do that and are doing it in the steps and stages that Saj has outlined.
Thanks, Paul. Thanks. Just to share with fellow directors, this is planning guidance that came out in the summer of last year, September anyway, 2021, from NHS England, saying that trusts' board performance reports should include a disaggregation of waiting lists by ethnicity and deprivation group. So I'm very grateful to both Saj and Paul for the clarity that they brought to the discussion here, that they are on with that, and I do recognise the challenges. Also, as chairman, I do recognise the difference between us understanding our waiting list perhaps a little better and what we're actually then going to do about it. I get that. So I promise I am not in any way sort of finger pointing anything here, but I'm passionate about us actually trying to achieve a better understanding so that we can be seen to be tackling what inequalities there might lie within our waiting list. So Sergeant Paul, I'm grateful to you for the attention you're giving, and if we can possibly be in a position, please, to publish by the next round of board meetings, I would very much appreciate that. Recognising the challenges. Rachel, I bring you in, and anybody else for comments on anything to do with the performance and finance academy work. So Ray, please.
Thanks, Max. So just to add really to what Sergeant Paul has said, so we know that from work done by the King's Fund that the most deprived sections of our communities are twice as likely to end up waiting more than 1 year for their care. We also know that the most deprived have increased by the greatest amount in terms of size of numbers of people on the waiting list. So we know those things are a fact. As Sergeant Paul said, it's quite difficult though just to look at all the sort of names and MRN numbers of patients on our waiting list and know from our EPR data exactly what that means in terms of do they have factors which would put them in the most deprived sections of our community. We do have an opportunity in Bradford, of course. So we've got the Connected Bradford data set, which is extremely comprehensive. For those who aren't familiar with it, this is combines the data for about a million people really within our footprint of Bradford and beyond. And this data combines information from general practices, from education, from ambulance services, so all sorts of different sources, and combined it gives a real nuanced set of information about people who might be in deprived groups. The data is anonymized, so obviously it has to be that way, but we do have an opportunity to link that with our electronic patient record to produce a much more nuanced, a much more intelligent analysis of our waiting list. Now, as Paul and Saj have already said, it sounds easy to do, but it isn't as easy as it sounds to do. But I think there's a real chance that we'll be able to do that. So we could understand our waiting list really quite well, I think. The real challenge, though, coming out of that understanding is what we do with it. So I've been in conversation with quite a lot of medical director colleagues from locally and within Wyatt and beyond across the country. There's one or two organisations who've done quite well understanding their waiting lists already. What they've not done quite so well is understanding how to use that information. There are clearly significant ethical issues in terms of what we do with that and how that deprivation would affect prioritisation. You know, we know that those who are least deprived are very good at self-advocacy. So what we need to ensure is that those who are most deprived don't suffer further by prioritisation. I think that's a minimum we should do. And, you know, recognising that self-advocacy will tend to push people up a prioritisation process and perhaps beyond clinical reasons. So the minimum we need to do is make sure that we're not further disadvantaging those who are most deprived, but we have to be very careful in terms of how we use that that data ethically, and making sure that clinical priority is kept, you know, the primary determinant of the order in which we treat people, and make sure that we do that in collaboration with colleagues both locally and on a wider footprint across the country. There's a lot of debate going on about this in medical communities, as you might imagine. So we certainly won't be alone in wrestling with these difficult ethical decisions. So the understanding, I think, is probably achievable, but dealing with that understanding is more of a challenge, I think.
Thank you, Ray. So Saj, Paul, Ray, I'm very grateful for your considered assessment of that position. We're just about to launch our corporate strategy, and of course we exist in part at least to tackle health inequalities. So, I mean, please do open up any other directors if you don't feel that we want to understand our waiting lists by ethnicity and deprivation as instructed in the guidance. But if anybody feels any different about it, I'm grateful for the considered assessment, and I'm grateful for the desire, I think, to at least get to a position of understanding. I do recognise that what you then do about it, of course, is perhaps a different matter, and may indeed involve acting as one in partnership arrangements, etc. So, yeah, okay. Mel, would you like to come in, please?
Yes, thank you, Chair. Just to reassure colleagues, clearly, you know, the sort of sentinel conversations around this as a concept emerged largely from the work that my colleague Owen Mullins had undertaken in Calderdale and Huddersfield, and in that regard, they were seen at the vanguard of considering this, that has now sort of shaped into the overall guidance nationally, and the expectation that we are able to do the first part of this, I think, which has been eloquently articulated by my colleagues, which is you know, finding those individuals who, within the sort of determination of those most vulnerable to health inequalities, those with living within a potentially a postcode that has an index of multiple deprivation that is lower than another area, or those with learning difficulties, or those with within a certain ethnic group. So there is a practical and pragmatic way that we have to address the issue of identifying those individuals and presenting that information. The much more considered approach that's required is, as we've articulated, what do you then do with that information, and how do you integrate that within the clinical judgments and expertise that are exerted in order to make the prioritisations? And is there anything in our pathway delivery that somehow disadvantages people from certain groups or geographical areas? So it is, you know, the complexity of this is acknowledged. There is a national ask, but there isn't any national guidance. There isn't an emerging body of evidence. You know, we've talked just now, haven't we, about research and the extent to which research is applied to something arguably far less complex than this issue. You know, that we've heard from Rebecca about, you know, how children might want to children, adolescents, young people access services, and the extent to which that is being tested rigorously in an academic and robust way, and yet we're expecting that we can somehow turn the raw data that we might be able to eventually present into a sort of an active intervention or outcome without really understanding. And when I spoke to Professor Wright about this, his advice was, as a minimum, we should wait for the emerging body of evidence to kind of, or even be a part of it, who knows, put ourselves forward to undertake some of this national research, which I think is very much needed in order to determine what the right approach is that doesn't then cause unintended consequences and potential clinical conflicts and disengages clinicians because you are arbitrarily challenging clinical decision making on the basis of where somebody might live. So I think there's a lot of work still to do in this area, but as that body of evidence emerges, and I know that there are places up and down the country, I'm aware in the Midlands, for example, they're doing quite a lot of work and are probably about to publish something that has helped them in their thinking about this. But we're not at the forefront of this nationally as a concept. We should have been probably 10, 20 years ago, but we haven't been, and now we're catching up to it. So the final thing to say is we are not alone. All the other trusts in Wyatt, including actually Calderdale and Huddersfield, are still in the conversations to try and come to a position through our West Yorkshire Association of Acute Trusts, and it's on the agenda for the next Wyatt programme board, because I've discussed it as the planned elective recovery lead with Lucy Cole, who's the programme lead for that.
Yeah. Thanks very much, Mel. Thank you. Okay, I'll just pause and see if there's any scope for further comments on that. I think we're agreed that as a group of directors, we would wish to be able to articulate the consequences of ethnicity and deprivation to our waiting list, and the sort of things they found in Calderdale and Huddersfield, which showed that there were clear relationships between ethnicity and deprivation and waiting longer for treatment. We all want to articulate that, but I get the point from colleagues that it's what you then do with that. I see that, but of course that doesn't mean we wouldn't wish to understand and be able to articulate that. Okay. Thanks, everybody. No further comments on that. We're content that the team will work towards having something we can articulate and publish for the next round of board meetings. But I realise that the action we may take, of course, will be subject to significant consideration. So thank you for that. Okay. Are we done on financial performance? Have we had the chance to, for Julie, Sarge and Matthew, to bring to our attention what we'd wish to hear? No further comments or questions? Great. Okay. Thanks very much. Shall we move to people now then, please? Let's take the people items, and then we'll take 5 minutes and come back to the audit assurance and governance matters for our consideration. So let's do people now. Karen, could I turn to you, please, as always, and ask for your thoughts and reflections on key points arising from the recent People Academies, please.
Yeah, thanks, Max. I'll try and keep this as brief as I can, and there is a lot to follow up on in terms of the agenda with looking after our people, the survey, staffing review. So I'll take the risks and the dashboard really quickly. So non-medical appraisal compliance reduced in March very slightly and is a focus for all of the CBUs. We saw a slight increase in temporary workforce in March. Staff turnover continues to increase, as we've predicted it would, and it will stabilise over the next 6 months. So we saw a very slight increase there as well. We have 267 people on apprenticeship programmes, and rolling absence for 12-month rolling absence is at 6.89, a slight increase, but actually the monthly absence is now starting to drop. So that's good news. In terms of risks, no change in scores, but there are 3 risks remaining. One around staffing, a big one. impacted by attrition, reconfigured wards and vacancies. And as I mentioned, turnover rates continue to increase, and we should start to see that stabilise in the next 6 months. But early retirement and moves to other industries are contributing to that, alongside the NHS not seen as attractive anymore. Something that we need to solve, really. Sickness absence, as I mentioned, overall has slightly dropped. January I reported it was high at 9.69, mainly due to COVID. But actually we're seeing those COVID absences reduce now as well, which is great news. So we ended up at 7.4% for March, but it is around 1% up year on year overall. I did previously report, I think at January's board, that Bradford was an outlier on absence, but that's no longer the case across Wyatt. Other trusts have been struggling with absence as well. And it's across the healthcare assistant portfolio that we're seeing absence the highest, and we're seeing more leavers in that category as well. And there's two groups of people affected by that. So there's an established group of HCAs, and there's a new group as well, a group of new HCAs. And there's different strategies that we need to apply to those groups. So, you know, working in different times, different pressures, staff being moved to different wards to cover, impacts on training and development, high volume of jobs in the local economy, particularly around retail, which are offering more flexibility and higher salaries, is starting to impact our numbers overall. But there is a deep dive being done around absence and attrition. And then appraisal rates as well. We've seen some issues there, but mainly because they've been on hold during the pandemic. There's lots of mitigations in place, so a huge amount of collaboration across all teams in the trust. We've engaged Just Our Marketing. They've been on site now, very successful in the past, looking at social media strategies for attraction, recruitment, retention as future mitigations. And then there's lots of here and now mitigations as well around recruitment, more matrons across the 7 days a week in the workforce hub, more huddles on a daily basis as well. And there's been a release of pressure as we've seen less COVID patients and bed bases getting back to normal, but as we've just heard as well, as more elective work kicking back in now, and we've got an exhausted workforce across the NHS, as we'll see in the survey results. Stress continues to be #1 cause of absence. It's multi-factor, so the mental health challenges of the last 2 years are certainly taking their toll, and it's not improving because now the adrenaline rush and the resilience has started to subside, so we are seeing issues. There's also a challenge for managers in referrals, so there's plenty of support, CBT therapy, psychology, OC therapy, staff counselling, wellbeing hub, Thrive, but it's about referring the right cases to the right area. So there's a triage piece of work that needs doing there as well. Work ongoing to build back togetherness across the trust and mend the fragmented nature of the workplace. We saw that loud and clear this morning, first thing. And as ever, a host of wellbeing initiatives to support people. But there was some feedback from the staff side that some of these initiatives are no longer having the same effect as they did earlier on in the pandemic. So we need to think about alternative wellbeing support. There is a work group that's been set up to have a look at how we look after our people, and the stress at work policy and wellbeing and attendance policies are under review. Medical appraisals were flagged. There's been 400 done, 40 plus doctors who didn't have an appraisal, but 2 to 3 months where appraisals were stood down. And there's 3 measures surrounding that. So L1 is where the complete, L2 was an agreed miss of an appraisal, normally around 10 to 20 seen, and then there's L3 where it's inappropriately missed, and we don't have any of those across the trust, and the NHS accept that there will be some L2s for various reasons. Just a couple of words on the staff survey. Pat will obviously go into more detail. Results were published at the end of March, very widely now. Nationally, over 1.3 million people invited to take part between September and December last year. 280 organisations, including all 217 trusts in England, participated in that as well. So some good comparisons in terms of data, and national key themes, as you would expect following the pandemic, and as you've heard in some of the issues we've talked about already this morning. Health and wellbeing, morale, and people recommending their organisation as a great place to work have deteriorated. Relationships with managers, working environment, and people feeling comfortable raising clinical safety concerns have all improved. There is a reduction in perception of quality of care and a slight decline in people feeling respected by their colleagues. Development and improving knowledge and skill, improved access to learning and development in the organisation have improved. Inequalities, very topical, small increase in ethnic background staff experiencing discrimination, with ethnicity the most common reason for staff to experience discrimination, with gender as the next highest reason, and an increase in proportion of staff experiencing bullying and harassment or abuse from patients, relatives or public, and this is higher for people from an ethnic background. And I won't go into the results for Bradford, but they follow a very similar theme. Great response rate though, 47.2%, with that's up on 2020, and I think it's probably the highest yet. Mid-range across Wyatt overall, just shy of 3,000 of Bradford's people participated, and some really impressive results across CBUs and services. So, for example, an increase of plus 23% in the nursing teams. Key improvement themes: improving staff engagement and morale, supporting staff better to understand the employee offer through Thrive, feeling valued, being one team, ensuring people feel confident and safe to speak out if something needs to change, well-being and burnout. There's lots of next steps. Again, Pat will talk about these. I think there's 2 or 3 things worth highlighting though. There is a focus group in plan with the staff side to focus on next steps and action planning. There has been a refocus. So you said what next? And this is an attempt to draw people in really to help support action planning based on those results. The staff side are disappointed in the results, and Bradford being below average in some of the areas, particularly around equity and diversity. But we are having a deep dive on those scores in May at the People Academy, and we'll report back through the board meeting. And I do think, based on the feedback and my experience as well, there is a need to involve people in that action planning overall. So, you know, the we said we did rather than we said you did, because that becomes top down in nature, and everybody across the trust should be responsible for the trust's engagement and culture and the experience of coming to work. So I think there's some really interesting things to come out of that. Likewise, we're also doing a bit of a deep dive in May's Academy on the effectiveness of the People Academy, and for similar reasons really, Max, as to the finance and performance one. So participation, contribution, you know, the execs and the non-execs talk a lot. There's not an awful lot of participation from other parties sat around there, but we would hope that there would be, and we need to drive that, but also really about value add, because we spend a lot of time preparing, minuting and having these meetings, and people spend a lot of time attending them. So we want to make sure that they get value add, and also that they hit the goals that we're there to achieve. So yeah, we'll report that back. I'll hand over. Thank you.
Yeah, thank you, Ken. That's fantastic, perfect detail. And by the way, I do know that all the chairs of the academies are speaking to each other about the deep dive work and the effectiveness work. So well done, you. That's great to hear, and terrific detail provided there. Thank you very much, Karen. I will pass to Pat. Karen, can I just bring to your attention, as chair of the People Academy, I attended the undergraduate education session that was held in Trust on Saturday, which is open to all sixth formers thought capable of going on to a medical degree, wherever that might be, of course. And it's led by Professor Alex Brown, and indeed I know Mel opened that, and I did see Paul calling in as well during the Saturday. I just want to share with you, Karen, as chair of the People Academy and with fellow directors, that it was superb. It was genuinely brilliant, and I sat through sessions in that, and the contribution from Trust colleagues to that was absolutely immense. It was really, really strong, and there was something in the region of at least 40 young people who were there. So what we're giving to young people there is an insight into that, and how, you know, how to do the statements, how to do the applications, but also an insight into medical work is absolutely brilliant. So I did just want to compliment. I don't mean to steal time from your briefing here, Karen, but as chair of the People Academy, I wanted to share with you that Professor Alex Brown and the team around him, which includes people from outside the trust who are coming in to support, GP was brilliant, are doing a superb job there. So compliments to them, and I wanted you to know that, Karen, that maybe that it's relevant to some of those that sit around the table with you. Pat, should I pass to you, please, to ask whether there's anything further from the general academy meetings, please?
No, like I think Karen's provided a really comprehensive summary of our 2 academy meetings. So obviously I've just got a little bit of an update on looking after our people.
Yes, no, that's great. Shall I just pause to see whether anything has arisen within our People Academy work that anybody who would wish to just query, ask for further detail on, support, endorse? No, it was a very thorough briefing once, that the detail was great, so thank you. Okay, in that case, we will move to item 17, which is the standing item of a reminder to us all of how we're looking after our people. I know lots of us are immersed in this, lots of us see it. There's just an opportunity for Pat to highlight anything she would wish. So please, Pat.
Okay, so just a few things. Firstly, we are using our staff survey results to review and refresh our health and wellbeing offer to ensure that it does still meet the needs of our people, as there is some useful data in there. In terms of, Karen's mentioned our sort of mental health referral pathways. We had the middle of April, we've had a new starter in terms of lead psychologist for staff support, Fiona Purdy, who's joined us. One of her sort of first roles is to review all our triage and referral pathways, and also to strengthen the relationship between psychology and occupational health to ensure that there's not a disconnect and to ensure that we're not missing people between those 2 services. So I think that will be a really valuable piece of work. I think from a staff side perspective, there's a bit of a perception that they have to see a psychologist, whereas actually a psychologist may not be the most appropriate professional to meet with them. So I think the work that Fiona does will be really key in that. The other area we are focusing on is the financial well-being of our staff in the light of sort of the continued rise in cost of living pressures, etc. So we are ensuring that we can adequately signpost staff to support services. We are paired up with Barclays, who are going to be running a series of financial wellbeing events for our staff over the next few months. And we're continuing to look at what we can publicise and help staff around sort of NHS discounts, both locally and nationally, ensuring staff are aware of salary sacrifice schemes, and ensuring that staff have access to adequate debt and financial management advice. So just really those couple of areas to focus on.
That's great. Thanks very much indeed, Pat, and compliments, of course, for the work that's being done there to look after the wellbeing of our people. Does anybody have any questions that might arise from that, please? Janet, please.
Thank you. I was bringing together Pat and Karen's comment just on one particular item. So in the survey, I noticed positively, you know, you're viewed as a learning organisation or a listening. I can't remember if it was listening or learning, but it was good. I think it was learning organisation. And we know from the errors from the some of the tragic reports we read, those organisations weren't listening, they weren't learning. So it's a real positive that is actually strong. And given what you're saying about, even though it's retrospective, how staff were feeling, I'm just wondering if the trust saw this as a springboard, as a magnet and traction to actually win the hearts and minds of staff. I'm just wondering if this is something that was in plan or thought about to build on that learning from each other, to enable people to almost bring them forward, because we're all coming out of the shadow of the pandemic, aren't we, in every organisation in the country. And I thought, well, there's one really good positive spark that might just be a good springboard to bring people with you. And I don't know whether that is a point or a comment to Karen or Pat. It's just an observation, looking at the papers and listening to you.
Thank you, Janet. Pat, thoughts?
I'll start. I think that's a really good point, actually, because that is the area where we see our best results when we compare ourselves to others.
Yeah.
And I think our areas of priority, we've focused in those areas where we haven't done so well. So I think that is a really good point to take forward. We will reflect that and look at what we can do, as you say, around that being a springboard.
Thank you, Pat. Janet, thank you, because that kind of goes with the academy point, doesn't it, about things that we're doing well. Well, let's do them even better. You know, let's not think that's okay and leave that, but we can really make something outstanding there. So that's a very well raised point. And whether it's listening or learning, let's hope it's both. But it's good to hear that there's positive views on that. So yeah, thank you. And Karen, yes, exactly. Thank you very much for your point in chat there. Yeah, thanks. Anything else that might arise? That's a good point, Janet. Thanks. Regarding the staff wellbeing, looking after our people. No, okay, that's great. Thanks, everybody. On the people side of our agenda, we do have Mel bringing to our attention anything in addition to the paper or anything you wish to emphasise on equality and diversity. And of course, we've got the nurse staffing review to approve. My suggestion is, shall we do those two first before then moving to the staff survey results, just so that we can take a pause, clear our heads and hear about the staff survey results. So shall I just skip to number 19 now, please, and ask Mel to bring to our attention anything she would wish from Equality and Diversity Council, and then to Karen. I'm saying that, but of course Karen's not quite with us at the moment, is she yet? So we might be flexible on that. So let's take Mel first then, and it may then be staff survey, depending on whether Karen's back with us. So Mel, please.
I think Karen is back. Yeah, I think I've seen. Yeah.
Is she back?
Cheers.
Great. Thank you. Thanks.
Thank you, Chair. So I'll take the paper as read. I will just highlight two or three areas. Firstly, civility in the workplace. The People Academy will be very cited on this, but this is about how we culturally change our approach to civility, respect, kindness. You know, you'll be familiar with our work in embedding kindness. And to this end, we've also engaged the services of a consultant called, oh gosh, his name escapes me, Chris, Pat might know, who is a real national leading light. He's an A&E consultant who first brought the idea of civility in the workplace as an initiative to prevent harm and to protect patients. And the sort of coined the phrase civility saves lives. He's going to be one of our keynote speakers at our leadership summit on the 20th of June, to which I think NEDs are invited. And if you could come along, that would be fantastic. That promises to be a really interesting and hopefully motivating day. The staff equality networks I've already mentioned, and the final thing I would draw your attention to is the work that John gave us a presentation on how we're weaving in the inequalities work. Max, you know, cognizant of your challenge and reminder that that's something that we've committed to do in everything that we do. John was able to share with us the approaches to service transformation that have gone approach those with through the lens of, are we paying sufficient attention to those who are perhaps most adversely affected by health inequalities that we know exist very strongly in Bradford. The emphasis on core 20+5, and we've similarly heard a number of times now from our colleague who usually joins the meeting, Sir Hale, who is the place lead on inequalities and indeed not just in our place but also at West Yorkshire. So I think there's lots of connections that we are making with colleagues at place and at the ICS level, and a very full agenda in this particular area. So just to highlight those, but happy to take questions.
Much appreciated, Mel. Thank you very much. Does anybody have any questions arising either from the paper or from Mel's leadership in this important forum? Nope, I think we're happy to do that. And so, Karen, I hope you had a moment to take breath and just think, oh, Max wants me to go to strategic nurse staffing review now, please. But of course, colleagues will have read the papers, and I thought perhaps if we take that now, consider whether we're content to approve that, and then we can just take 5 minutes and we'll come back to staff survey and deal with our governance issues before closing this open meeting. So, Karen, may I turn to you, please, to bring to our attention the ask of the board.
Thank you. So within the bundle, there's a number of papers referring to review of nursing and midwifery staffing. This is a 6-monthly review that we do. You'll remember at the last 6-monthly review, we included reconfiguration of wards, including the COVID wards. Moving on for this review, so when we look at the general nursing side, there have been some changes. So we have less COVID patients. COVID is behaving differently than it did 6 months ago, and less need for certain types of beds, namely an IV. So there is actually a reduction on the ask for staffing compared to 6 months ago on the whole. But as Matthew reminds me time and time again, this was always non-recurrent funding on the back of COVID. What I would like to say is that as soon as the ink was dry on this paper and it went to committees, we are then in the process of reviewing it and updating it again, which tells you the fluid nature of this. So it is unusual that we're asking for a reduction in nursing staff, but it is on the back of changes predominantly with COVID. However, there are some additional asks within this. So we made an agreement that all wards would have at least 1 Band 7 and 2 Band 6 junior sisters. That's for a number of reasons, for leadership, for consistency, but also to help with succession planning and how we move people through. So one of the wards didn't have that, so there is an ask for a top-up to create that post. We know that when we moved wards 20 and 21 to wards 2 and 5, so these are our urgent surgical wards, we also moved the staff that staffed the higher dependence beds that were on there. We've since reopened wards 20 and 21 as elective units, and we know that we have a number of patients that come through that unit that need enhanced care. So this isn't quite the level of intensive care or HDU care, but it's enhanced care and requires a higher staffing ratio. So therefore, there is a request of £207,000 to staff these beds. It does two things really. It allows us to get those big cases through, but it also means that we will not logjam our intensive care unit and our precious HDU beds. There is an additional ask in the paper for a deputy matron in specialist medicine and a COVID clinical educator, £109,000. Since writing this paper, we've reviewed that, and it's just now a request for the deputy matron, although there is an additional ask against this, as we are doing our reconfiguration and looking at how we look at the senior hierarchy and the leadership structure across the trust. We currently have 3 8B deputy associate director of nursing posts, and we are moving to 4. So there's an additional post that again allows progression through the senior nurses to enable us to attract people into the trust as well. So that is the overall ask. So once it is a reduction, there will be a further reduction on the baseline budgets. I'm all right, thank you. On the baseline budgets, because we have now, since this paper was done, closed another COVID ward, and we are also reducing and reviewing the staffing levels on our respiratory ward because again, we had an enhanced level of nursing on there because of the way we had to wear PPE. So those will change over the next few months as well. Within the bundle, and I think it's quite useful. So Appendix 1 shows you how the number of beds have moved over time. And you can see that in 3 fixed points in this calendar year, the beds moved significantly to what they are. And then also there is an updated ward list. So this was good at the end of February. Again, as good as the day it was printed, but there's an update of what every ward is, who the key contact people are, and the function of that ward. And as an exec, we've been looking at that and thinking, how can we make that more current and keep it live and update that so people have got that information to hand to the fingertips. So that's the nursing review. Moving on to the maternity review. Again, we did a very substantial review of maternity, including red flags, and using the tools that were available to us as well, which is commonly a tool called Birth Rate Plus. And we worked out our revised staffing levels based on the number of births that we have to deliver 100% continuity of carer. You will note in the latest Occupant report, it does say that we shouldn't be doing continuity of carer at all costs, but we should be doing it a staged and managed way in the way that we can recruit to these posts. So therefore, the maternity proposal going forward is that we stage the way we recruit to these posts, knowing how midwives come into the system, how they qualify on a yearly basis. We're also looking at some overseas recruitment. So that means that we are aiming to have 35% continuity of care reached for the first 6 months of the year, going to 50% for the second 6 months of the year, with a review in a year's time to move forward towards that ultimate goal of 100%. And again, anybody that's seen the series on BBC Two will know that continuity of care and that relationship between the midwife and the woman and the then baby and family is really crucial to a really good outcome and experience. So I will leave it there and open up for any questions. Thank you.
Thanks very much indeed, Karen. So, and are we all directors clear of the ask in terms of the recommendations shown in the paper? Yeah, I think we are. Okay, so any questions, please? Any further detail required? Are we content with the briefing from our chief nurse? Janet, would you like to, do you have a query?
I don't have a query, I have a comment, and just thank you, Karen, for the detail and the very clear explanation. It's very reassuring and understandable and logical, and thank you for that.
Perfect, thanks very much indeed, Janet. Yeah. And again, colleagues, did anybody feel there was anything further they wanted to check on? It wouldn't appear so, and so we're content to approve the recommendations, please, that are outlined in the paper. I think we are. Yeah.
Thank you.
Thank you, Karen. I think we're all assisted. That's great. Thanks very much indeed. Okay, right. I'm just going to call a break for 5 minutes now. I have 18 minutes past 2 or 19 minutes past 2. It's just turned 2 on my computer. So shall we reconvene at 25 past? Shall we just take 5 minutes? Give the chance for the kettle to boil, and we'll get back in and talk about the staff survey results. I know Pat's going to highlight the key themes, so we'll hope that we'll have read the papers, but I just thought we should just clear our heads and get into the staff survey, yeah? Hopefully then the governance matters are reasonably transactional, people will have a chance to see them, and there's very minor amendments, isn't there, in them? So 25 past 2 we'll resume, yeah? Okay, thanks everybody, thanks for sticking with it.